So, good afternoon to all. On the behalf of Walter Bushnell, I, Pratham Jain, welcomes you all to the live webinar on the non-surgical and medical management of hemorrhoids. I also welcome all the delegates, panelists, and audiences to this webinar. Now, I would like to hand over the session to Dr. Arun Baksala. Dr. Arun Baksala is Deputy Head Medical Affairs at Walter Bushnell to further take the session ahead. Dr. Arun Baksala.
Thanks, Pratham. A very good morning to all of you on this Sunday noon. On behalf of Walter Bushnell, I extend the thanks to all of our audience and to our speaker. And so we will be waiting for about a minute or so because more participants are joining. So we will be waiting for about 40 minutes and then we start because I can see some of the participants, they are joining. And
Lata.
A very good afternoon to all of you. My name is Dr. Arun Baksala. I'm Deputy Head Medical Affairs, Walter Bushnell. On behalf of Walter Bushnell Healthcare Foundation, I extend my thanks and gratitude to all the audience who have joined us for Sunday webinar. The topic is non-surgical and medical management of hemorrhoids. We are lucky to have with us Dr. K. Kumar sir, and I'll be introducing him. He is graduate from Madras University, Chennai, and he post-graduated from Tamil Nadu Dr. MGR Medical University, and then he super specialized in gastroenterology from MGR Medical University, Chennai. Presently, he's a senior faculty at Madras Medical College, and also he is associated with Apollo Specialty Hospital and St. Thomas Hospital in Chennai. He has been assistant surgeon in Tamil Nadu Medical Services, and he is designated postgraduate teacher and guide for many of the postgraduate students pursuing DM Gastro. And he has numerous research papers to his credit in various journals. He has presented papers in national conferences conducted by Association of Physicians of India and the Indian Society of Gastroenterology. Sir, on behalf of Walter Bushnell family and all the audiences who has joined us for this webinar, I formally extend my welcome to you. I would like to hand over the session to you now. And so, welcome, sir.
Thank you, Dr. Arun Baksala. At the outset, I would like to thank Mrs. Walter Bushnell for this opportunity. I'm really happy, proud, and privileged to introduce my teacher, Professor Raviya Narayanan. And it's a very proud moment for me. Sir got his MBBS degree from Madras University in the year 1967. He got his diploma in child death degree from Madras University in 1973. He did his MD Pediatrics in 1976, and he did his DM from Madras Medical College. He has been practicing gastroenterology for the last 39 years. And at present, he is heading the Department of Pediatric Gastroenterology at Kanchi Kamakodi Children's Hospital in Chennai, which is one of the most premier institutions, private institutions for pediatric healthcare. And he's been an advisor of Pediatric Medical Foundation. He has got, he's a multifaceted personality, and his areas of special interest in gastroenterology are liver problem, treatment of hemorrhoids, stomach problems associated with intestinal disorders, digestive issues, abdomen pain, gastritis, acidity, and etc. And he has been a popular speaker at many national and international conferences. I'm very sure that, because I'm being a student, I can really tell that, he has got a very large, very basic practical experience. In fact, apart from books, we need more practical experience in treating patients. So I'm very sure, I'm 100% sure that you will be able to enjoy his talk as we used to during our DM days. Over to you, sir. So muted.
Sir, unmute yourself.
Now?
Yes, sir.
Right,
Perfect.
sir.
Okay, right. Is it visible now?
Yes, sir.
Okay. Good morning, everybody. I'm so happy that Professor PREM is with me to give maximum academic support. And thanks to Walter Bushnell, Professor Pratham Matthews, as well as Arun Buxley and all other team who have done a wonderful job now to convert it into a national webinar. I'm sure at the end of our discussion, I think all your doubts can be cleared. What little we know, we can share with you. I'll straight away go to the topic. It is office management of hemorrhoids. What a practitioner should know. I think it's not moving. Hemorrhoids, also called piles colloquially, they are nothing but almost varicose veins like bundle of dilated vascular channels in the lowermost rectum between the anal mucosa and internal anal sphincter, which is very, very active in most of us, particularly in high-risk group. Who are all the people who can get this problem? Pregnancy, of course, postpartum, we do see. And a person who strains too much, increasing his pressure load, not only in the stomach, but also in the respiratory tract, is another one. Then those who have sedentary habits, particularly sitting for a longer period. For example, I have included hemorrhoids as part of software disease. Then those who sit for a longer period, like a cashier in a bank, or the driver who goes for a prolonged time using the car or lorry, those people are likely to get it very often. Then those who take less fiber diet, fond of junk foods, yes. Those who stand for a longer period, like any traffic police inspector, as you see there. And this picture also shows Particularly, he is not only a standing man, but also he has accumulated a lot of fat in his body, very obesity. And those who go on scratching the buttock due to chronic itching or constipation, chronic, particularly who strains too much and spends more time happily in the restroom. Then those who are not using the health wash but try to use the particularly the toilet papers. Then those who go to the gym and strain too much every time and wants to be the Mr. Madras or Mr. India. Of course, I have already told you this type of the figure with very high BMI of probably morbid obesity of more than 40, they are all more prone for the hemorrhoids. What actually happens in these people? Prolonged standing or sitting, low fiber diet, constipation, so many things which we have narrated now. When a person strains to pass motion, particularly a lot of pellets which will not move, pasty, dry stool which will not move, and hard, large, dry pellety one. And when they get accumulated, the rectum also get dilated. It can accommodate to a certain extent. Beyond that, it can cause pressure symptoms on the veins of the rectum, and intraanal pressure goes up, and decreased venous return, enlarged hemorrhoidal venous cushions will be there. Then the veins become enlarged, tortuous, and they start prolapsing down, and the cushions also comes down, and loss of connective tissue support, and susceptible to trauma and hemorrhage. We have heard about, when I start talking about cushions, I would like to know what is a cushion, because that gives you happy. Cushions are normally present. It is in the submucosa, clusters of vascular tissue, connective tissue lined by normal epithelium of the anal canal, fibers, muscle tissue, all put together, they form a very nice cushion, which is normally present in everybody. I can say hemorrhoids are present in everybody. The hemorrhoidal disease or piles or the classical symptoms may manifest when there are high risk factors in a person. The three cushions primarily form the primary sides. They are 7 o'clock in the right posterior, then 11 o'clock in the right anterior, and left lateral 3 o'clock position. Of course, this is an advanced case of hemorrhoids where you are able to appreciate the secondary pile masses also there. Primary pile masses are 1, 2, 3. These are the three things when you see. So, what is it that I wanted to know from this slide, or remind everybody who are listeners who are not oriented, is if you are going to see the engorged tortuous veins elsewhere in the lower rectum, particularly, you have to rule out other causes also. That is very important. They are called secondary pile masses, and secondary cause like portal hypertension, you have to see. The physical examination, you have to see the rectum in all cases of cirrhosis liver, so that you will not miss the extra primary lesions. Colonic malignancy should not be missed in these people, can produce a pressure effect. Enlarged prostate in the early, these are the three common things I thought I may have to remember when I deal with a child with piles. As you see here, the clinicians always are fond of doing more and more knowledgeable researches. So one is, this is a simple one where you have a lot of redundance of the tissue of the skin hanging. skin tags are there, and from that you get a thrombosed external pile mass. This is an external hemorrhoid, distal to the dentate line and covered by squamous epithelium. So usually, why do you want to know about whether it is above the dentate line or below the dentate line? If the pile mass is above the dentate line, it is lined by columnar or transitional epithelium, and usually there are no somatic nerves, so they may not cause much pain if it is not complicated. Whereas this external pile mass is lined by squamous, and so they can cause pain also if it is thrombosed. Then if you can get an internal pile mass as well as an external pile mass, the combination also you will get in advancing cases. We call it as mixed hemorrhoids. Now, this is the classical example of a skin tag, which many of them, when they hand wash, and they may be able to feel it, but that is not going to cause any symptom. We are not going to treat that also. It is nothing but, we will tell you the redundant skin due to subclinical inflammation, edema, and thrombosis, ultimately like that. So usually no symptom in external hemorrhoid, no bleeding. It is seen and felt by the candidate and represent only the redundant skin from external hemorrhoidal subclinical inflammation, edema, and thrombosis, which I just told you. The skin tags are typically seen in younger generation and middle-aged group, rather uncommon in older age group. Don't ask me why. Probably because of aging, they get shrinkage. Thrombotic complication may come in external, which we present as an acute thrombosis, and they may cause pain, and overlying skin may become little taut and stiff, and it may become bluish in color, and they can start ulceration and bleeding, sometimes secondary infection. What are we going to do for this external hemorrhoid? Reassurance, proper anal hygiene, avoidance of wiping the area with hard tissues, and the surgical excision combined with internal hemorrhoidectomy if it is a mixed form or if it is a thrombotic nature. Small tags usually may not need any treatment. Cryo surgery is not practiced even for internal surgery. I'll tell you later why. And the treatment of thrombosed pile mass is, people will go to the physician or gastroenterologist or surgeons. If it is painless, reassure, and it will gradually tell them that it will subside in several weeks' time. Nothing to worry. When painful for less than 3 days, that means it is an acute onset, you may have to interfere by doing an excision, calling a surgeon. And if it is not treated, the pain may subside in 4 to 7 days. Excision not very helpful in these people. We don't interfere. Masterly inactivity is better in these people. Because the difference between the surgery and no surgery in acute, particularly if it is lasting for more than a week, it is not going to matter much. But severe pain enucleation may be done for these people under local anesthesia. Of course, you remove it. If surgery is not performed, and if the patient is not willing for surgery, defers surgery, then if there is an absolute indication, what is that we can advise? Routinely applicable to all the people with hemorrhoidal disease. Sitz bath can be given. I normally believe rather than sitz bath is a cumbersome procedure and you have to get a big tub and do as you want, as advised by the experienced people. I will normally advise from ring pillow, cotton pillow, as well as that ring pillow should be used like a mobile, wherever he goes and sits, he can use it. It is always better, I tell them. And most of the people do well, better than sits bath. If the pain is very severe, you can use analgesics like paracetamol or acetaminophen, and a topical ointment like probably witch hazel or anal fat or sucralfate containing a little lignocaine may be helpful in these people to lessen the pain. Something I thought I have learned when I was preparing this topic about what is this SITS procedure. SITS means sit. So how to make it more successful? It's a procedure, very simple one, usually recommended for persistently prolapsing hemorrhoid. We call it as grade 4. I will come to that little later, the grading. The general practice is to give around 10 to 15, 20 minutes. They have to sit in a big tub of warm water, and 2 to 3 sessions a day will help them. Some of the people may enjoy, some of the people may feel cumbersome. Take a sitz bath in your bathtub, fill it with enough warm water to cover the area, and simply dip the affected bottom area for sitz bath. That will help them. Ring pillow, this is the one which can be very easily got from anybody who is very busy with mattresses stitching, and he will help you by taking a measurement. Too little or too big, both are not going to help your people. You have to order for a correct size. I normally tell them in Chennai, just opposite Valur, you have a very wonderful fellow. Whenever anybody enters, he first asks the question, are you coming for ring pillow? So commonly used, and I feel it is very successful in this, particularly who sit for a longer period. Sitz bath, how does it help? Great relief of symptoms of piles such as pain, itching, swelling, soreness, inflammation, etc. And with the help of a attending gastroenterologist or surgeon, you can add few additives to this warm water, like Epsom salt, witch hazel, or apple cider vinegar, which is sold in most of the supermarket, or non-iodized sea salt or common salt, and of course olive oil can be few drops, or povidone solution can be given, can be added to this water for sitz bath. If the doctor prescribes sometimes local ointment, I told you, anal fat or so many sucralfate like that, I think that should be done after the bath and not before the bath. Internal hemorrhoids, they are above the dentate line, and they can present in variable presentations. They are more concerned for little more experience with expertise, and gastroenterologists or surgeons will usually tackle in office practice. And I don't go to the theater. I do it in my endoscopy room. They are associated with high levels of the circulating matrix metalloproteinases, and particularly who have constipation and loose stools, or with where they strain also sometimes. And there is always a neovascularization with CD105 immunoactivity. CD is something where a chemical released from this congested area into the circulation. And long distance drivers are not exempted, they are also included. Two major complications we do see in internal hemorrhoids. They are usually painless spots of blood, or in the viper pepper, or in the flush, they see maybe mixed with hard stool, or drops of blood may come after passing a hard stool. They are usually fresh blood, painless bleeds, intermittent bleeds, very typical. Torrential bleeds are very rare, and if they collect in the rectum, probably you can get clots, red clots, dark red blood. The second symptom is prolapse. That's an annoying one, and they immediately report to the doctor. They are graded also. So grade 1 is bleeding is there because of enlarged the cushions coming with vascularity, but they don't come beyond the anus. It's not felt or seen. That is grade 1. Grade 2, the same thing comes out, but they can reduce spontaneously. Grade 3, same thing, but you have to push it inside the moment soon after defecation. Grade 4 is it refuses to go in, and it comes out, and you are able to feel, you are able to see, and they are complicated, and they are likely to bleed also, particularly may force surgery also. I will give you the indication later. So these are the 4 grades or conscious grades. This I thought I will share with you. This is our external pile masses, but you are able to see the very slight one. The moment he passes the motion, he is not able to see anything or feel or any such thing. Grade 2, it comes out and goes in freely. And they have got permission in grade 2. In grade 3, they have to push it in. In grade 4, they are persistent. I hope I'm very clear. And for PREM, can I continue or confusing?
Sir, please go ahead, sir.
Okay, thank you. This I have seen in several patients, external tag of skin and thrombosed one, and of course internal, external pile masses which has cracked now. They can cause pain and bleeding. You are able to see the mixed one with different types you can see. Right. Now, how are we going to make a diagnosis? One is history. These people, the potential high-risk people, you got to suspect first. Don't bypass history. Don't bypass rectal examination. If it is highly painful and if there is a streaks of blood coming in a constipated patient, prolonged sitting posture patient, then suspect fissure. Don't do rectal exam. Just see, and then that is enough. Inspection. Otherwise, painless bleeds, you have to do a rectal exam. 2 things. One, you may be able to feel the pile mass. Second, thrombosed pile mass also can be felt. You can also appreciate the traffic jam, the loaded colon rectum is also that type of motion, etc. You can also find out in these people when they are sitting in probably for a longer period, like software, they try to contract the buttock, they try to contract the anus. So retain the motion and try to pass whenever they want. They cannot pass motion. That's the difference between urination and passing motion. Whenever you want to go to toilet and try to strain, you cannot get the motion out. You will pass only dribbling of urine. Urination can be anytime, even if you hold, but motion, unless there is a sensation, you cannot pass motion. Remember that. Now, what are you going to see? You can use an endoscope, plastic or metal, with the help of your touch simply in the OP. You have to lubricate it with lignocaine 2%, and somebody can put a torch. I think I'm not exaggerating. In a week, I see at least 3 or 4 patients. My reception staff helps me in my own chamber now. I am not going to hospital today, nowadays. Endoscopy can be beveled or slotted. And if you just adjust and then do, you may be able to appreciate this. Normally, we go anteriorly and then posteriorly. You may be able to adjust little eversion that will give you the prolapse coming inside the endoscope, as you see here. Of course, gastroenterologist, we have to use the colonoscope, flexible one, and we can retroflex and see the multiple hemorrhoids of mixed type. Usually, the position that we offer is left lateral position. The lower leg can be straightened. The left one can be straightened. The right one can be bent. And then you ask the patient to retract the gluteus and have the good darshan of the ENS and try to pass the endoscope or proctoscope. And both are different. The only thing is a little longer, and you have got different sizes, and try to remove the operator and see what is there, a good darshan of the prolapsing bile bars. The treatment, of course, initially holds good for everybody, sits bath, good hygiene, and we try to give more fluids, and then we try to give good fiber, maybe 20 to 30 grams, and of course, then lifestyle modification, tell them not to sit for a longer period. If a person is sitting for 1 hour, for 15 minutes, he has to get out and then walk, go to for any beverage or talk to somebody. And of course, even a banker can get up and go in a bank, cashier. Avoidance of straining, prolonged sitting, toilet, etc. You have to avoid in these people. If the stools remain very hard, then stool softeners can be given. Disinfection can be done with polyethylene glycol, 3350 molecular weight, or docusate sodium can be given to these people when fiber alone is insufficient. And laxatives and enemas are little rarely I use it, or it is recommended. If there is going to be pain and itching in internal, then topical creams can be applied containing lignocaine, hydrocortisone, and of course docusinate, etc. And that can also be used. Of course, suppository has little role in these people. If the patient comes with an acute problem, we can use phlebotomics, nothing but improving the symptoms, and they try to give neovascular resistance, but they reduce the vascularity and anal pressure. And plant extracts, only one product, psyllium, is available. The rest of the things probably are flavonoids. I'll come to that little later. There are only 2 types of tablets as well as the anal creams available. In what way they are helpful? Improve venous return, stabilize capillary permeability, alleviates bleeding, and they are safe. Many of them are sometimes there are few things or well studied and documented like venous spin. When they are particularly they may contain diosmin or diastemic plex usually, or with hesperidine also may be there. Now coming to the local ointments, psyllium cream is there. It contains particularly the extract from the grape seeds, and they contain different combinations also. Praxirutine is an antioxidant. Calcium dobisalate, venotonic drug. Zinc, supposed to reduce the itching and burning. Phenylephrine, decongestant. Lignocaine, local anesthetic, which I normally use for my patients, particularly whether the pain is less or not. Locally, it is effective. Then you get, this is the classical. The hemolyte is also almost same. Pillow root, of course, contains domiciliate and proxyroutine combination, which can be also used. Whatever, I leave it to your idiosyncrasy. I am not very particular about you ought to use this, that, etc. Anyway, cream, particularly for a long-standing painless, particularly piles, and which contains phenylephrine, beclomethasone, and anti-inflammatory, and lignocaine, pain reliever. So, as you think, ultimately, in due course, you can appreciate the related shrinkage and in the affected area and decrease the swelling, prolapse, etc. Then you get sitcom LD, which contains herbal, euphorbia, dry extract, ethanolic cream, can be used along with the sitcom tablets also. Relief, very good for chronic fissure, not for pile masses. It is supposed to heal the pile mass, which contains nifedipine. No oral, but it can be applied only locally, twice a day. Sucral Eno, sucral coat, sucral fate, etc. They contain particularly sucral fate, metronidazole, and lignocaine, which is a combination. And I don't know how metronidazole helps, but the other two definitely, sucral fate and lignocaine, is definitely can reduce the anal pain and irritation. Now, with reference to oral drugs, particularly the phlebotomics, diosemics combination is well studied, documented. I will show you two studies also in my future slides. Ideally suitable for grade 2, grade 3 hemorrhoids. There, one is, of course, vasculera, which contains high dose of diacetyl, and vein flow also contains diacetyl and hesperidine. Venusmin contains purified micronized diacetyl, and that contains in different probably strength are available. You have 150 milligram, 300 milligram, 450 milligram, 900 milligram. Though it is little cost prohibitive, I hope the company will come forward to help us. I normally request whenever it is very costly, I think you can also follow. We will talk to the representative and the dealer, the person, ask them to supply direct, bypassing the dealer, stockist, and pharmacist, so that it will come to at least 20 to 30% discount. Why? The issue is, whenever you use a very costly drug, the patient may take, if you say 2 times a day, 3 times a day, like that, they will take only for a few days. They cannot afford. That is the problem. That is why we try to help them. And second, there may not be any substitution from a pharmacy. Third, of course, you can avoid in a crowd in a pharmacy during Corona time. So, diacetyl pure micronized purified flavonoid, colloquially called as MPWF, consisting of 90% of diacetyl and 10% of hesperidine, is the most common flavonoid. Even venusmin, then vein flow, they are all containing more or less, but the strength is different in venusmin to suit the condition. It's a well-studied and well-documented drug. I'll give you quote an example. The experience of the documented journal recently is, of course, is 2 tablets, 450 milligram twice a day, for 1 week. Then 1 tablet BD for 2 months. They have studied in 66 patients. Primitive hemorrhoids, particularly primary, grade 1 to 4, they are not secondary hemorrhoids, has confirmed expectations. It was efficiency in relieving the pain as well as bleeding, and the value of 98 and 86% in the second week of therapy. Even for acute bleeding, and you can use probably in 2 to 3 days time, the vessels shrink and then they are able to get good relief. The excellent tolerability, that is very important. Compliance makes the diazepam very handy, useful drug for the proctologist to prepare the patient for subsequent treatment. Daflon is also micronized, purified flavonoid diazepam with hesperidin. It contains 500 milligram of the diazepam and small dose of hesperidin. It's supposed to be venotonic and vasculoprotective. Usual dose that they recommend here is the orally, the 4-day course of 6 tablets daily for acute hemorrhoidal attack, and followed by 4 tablets daily over next 3 days. Now, how does it work? The diazepam, blocking the chemical messengers, prostaglandin, thromboxane A2, etc., reduces the inflammation, improving the blood flow, block in the blocked veins, or at least produce new air vessels and reduce the inflammation as well. So this is supposed to be another drug which have been there. A general information: flavonoids mixture, diazepam, troxyrutin, hesperidin combination. So it's supposed to be multiple drugs combination, combo pack in the treatment of acute hemorrhoidal disease. The prospective randomized triple blind as well as controlled trial say that it is very useful and effective. Then they have also tried in a multi-centric trial, particularly the clinical trial versus surgical trial. They found that effective in eliminating symptoms in these people. The MPWF, consisting of this combination, has been very favorite for many people. I have attended one of the lectures of a person who had more experience, and they found that it is very useful. Maybe risk of bleeding is less by 67%, pain 65%, itching 35%, etc. So some people even feel investigated on the foci of rectal discomfort, pain, and secondary hemorrhage after post-hemorrhoidectomy follow-up. So this has been published in World Journal of Gastroenterology. Diazepam is a flavonoid from citrus fruits, and it's also an antioxidant. And it's supposed to help both to treat internal and external thrombotic hemorrhoids. Studies have favored this drug, and of course, they have also found that diazepam is effective in eliminating post-operational symptoms of hemorrhoids. So finally, what they have suggested, diazepam has shown to be effective in eliminating symptoms after hemorrhoidal surgery. Also, this has come in, of course, the World Journal of Gastroenterology. The next drug that we can use is oral calcium dobicelate. This is another venotonic drug commonly used in diabetic retinopathy, chronic venous insufficiency, as well as in the treatment of acute symptoms of hemorrhoids. So it is supposed to help decrease the capillary permeability, inhibited platelet aggregation, improved blood viscosity, thus resulting in reduction of the edema also. So the World Gastroenterology also favors this. The classical example of troxyrutin with oral calcium domicelate is Oxyrute CD from Ford's company. Psyllium tablet is purely from grape seed extract. It contains proanthocyanidin and vitamin C, antioxidant, anti-inflammatory property. So ultimately, I don't want to confuse you with, I'm not taking a pharmacology class, but what I wanted to convey, there are certain drugs, whether you know the effect or etc. The only choice is, of course, you have no other alternative to particularly grade 2, grade 3 hemorrhoids with bleeding and complications. Venusmin, yes. Vein flow, yes. Teflon, yes. Then sitcom, okay. Psyllium, yes. Oxyrute, okay. These are some of the drugs which you can start using in these people. Of all the things, I dare say that Venusmin has been well studied, well documented, and it is supposed to, can be safely recommended. The other drugs, though they have the equal combination, but more or less similar in pharmacological contents, but the studies cannot be compared with Venusmin. Sorry. Suppose if the patient is not responding well, can I take another 10 minutes, sir?
Please, sir.
Professor PREM, right. Medical treatment, if it is not responsive, particularly if the patient comes with bleeding, prolapse, and grade 4 prolapse with persistent prolapse, then you have to go for procedural, alternate, don't depend on only drugs, but some other methods, which could be a procedural therapy, non-excisional or excisional. Today, I am not going to touch upon excisional surgery, particularly in grade 3, grade 4, the hemorrhoidectomy, procedure for prolapse, and of course, laser surgery, etc. I am not going to talk today. But my foci will be little more, apart from drugs, apart from local topical, non-excisional. What is that? They are designed to affix the vascular cushion to the underlying internal sphincter. They don't want the cushion to come down, and they don't want vessels to become prominent. So you can do rubber band ligation, what we call it as RBL, particularly useful in grade 2, grade 3. Sclerotherapy for all, if the patient is not willing for surgery. Cryo surgery, nobody does. I'll tell you the reason why. Because not available, takes time. And when you do cryo surgery, you not only deal with the file, but also deal with the other tissue also. A little over enthusiastic, so it is left off. So I will not be touching more on cryotherapy. Infrared coagulation, some places they do. So will be discussed today. The band ligation, what is that needed? I have done it with proctoscope. I have done it with colonoscope. Colonoscope, it is more convenient. I have used proctoscope, also using the colonoscope inside. That's also popular. So the doctor inserts the endoscope into the anus. The hemorrhoid is seen very nicely by adjustment. You see the prolapsing hemorrhoid alone and try to grasp it with the instrument. If you are using a colonoscope, you suck it, it comes nicely like a varicose vein, and then try to release the band. That's very nice, rubber band goes off. And the hemorrhoids then in due course, in a matter of around a week or more, sinks and dies. and becomes about a week, it falls off. The problem here, sometimes if you use the venotonics and then continue immediately, the veins may shrink, the band may fall. So 1 week before and 1 week after, we don't use two things. One is the phlebotomics, the other one is a blood thinner. These two, we don't use it. Now we do, before you take up this procedure, the COVID testing also. I have used long back the procedure of a device also. You have got to try to fill it up with this band and try to use this like this. This is also possible. You got a device of release, band releaser. The studies regarding this banding show that it is feasible, simple, safe, efficient, inexpensive, good, particularly when compared to the other modalities, the excisional surgery. The retroflex one, I have sucked out and applied the band very nicely. And usually we do only one banding. The multiple bands in one session is better avoided. Number one, it is painful. Number two, motion gets bent up, high up. Number three, discomfort, etc. Most common office practice applied to second and third degrees, unresponsive to drugs and supportive measures or the conservative methods. In addition to creating a scar and fixing the mucosa to the underlying tissue, a small amount of hemorrhoidal tissue is actually removed in this procedure because of the necrotic area and sloughing out. It takes away that also. Single band is used usually to avoid infection, particularly in a diabetic as well as immunocompromised people. We normally give bowel complete evacuation, clear the entire traffic jam and try to do. No need for any prophylactic antibiotic. Bands are placed proximal to the dentate line, particularly whenever you try to suck out and then you try to apply the band almost in the base of the pile mass. The proximal to the internal pile mass above the dentate line. But what is that to be remembered in this procedure? Distal placement, distal to the dentate line, entraps the squamous tissue and causes severe pain. Whenever he complains of very severe pain during or immediately after the procedure, better you remove the band or reposition the banding and then redo it. So, banding is not usually indicated for external hemorrhoids. Single band during single procedure, I told you, reduces the pain and other complications. Multi-bands, if you are going to apply, better to give a local anesthesia or a general anesthesia with the help of an anesthetist. What about the follow-up of these people? The banding in about 4 to 6 weeks. If needed, you can repeat again the second sitting banding. And maximum 3 times be taken. If the patient needs more than 3 procedures 3 times, better submit for surgery or other procedures. Mild pain may be there, and then you can give the cyst bath or a ring pillow or paracetamol. Again, one more point to be remembered, phlebotomics and blood thinners should not be used before 1 week and after 1 week of this procedure because the band will fall. Then more fluids and fiber diet, conservative, hygiene, important. What is the outcome of this procedure? Grade 1 and 2 hemorrhoids, if you use 75%, grade 3, 65%, and success rate Recurrence can be prevented to 20% in these people. Complications could be minor and major. Mild bleeding, pain, vasovagal symptom. I have not come across anything. These are all minor, ignorable. But massive bleeding, thrombosed hemorrhoids, severe pain, urinary retention, all those things, infection, some surgical complications, you have to be a little more careful. Bleeding, if it is there, then particularly when it sloughs out, it normally occurs after a week or 4 days, and there is no need, it's self-limiting. If it is massive bleeding, you can do to arrest the bleed, like a variceal bleed, you can use a rectal tamponade. What is that we use for this is, you can give the epinephrine, adrenaline, locally diluted one, find out the site of bleeding for the paravascular region, or you can do a the suture ligation, or Foley's catheter, large size, can be filled up and little pulled up, probably the bleeding may arrest for a day. So anticoagulants, 5 days prior and 1 to 10 weeks post procedure, I told you, should be avoided in these people. Infection can be tackled with antibiotics, and you can do suture ligation if there is going to be a bleeding with infection. No prophylactic antibiotic for these people. Surgical debridement, IV antibiotics can be done after hospitalization. What is anything new in banding? Number one, the CRSO region banding system is on the way, and CONMED space bander. These are the two things which have to be analyzed, studied in India. Indian scenario, I think I have less information regarding this. Now, sclerotherapy, polydecanol or ethoxyclerol or STDS, sodium tetradisulfate, quick, painless follow-up after 6 weeks. Patient can go home like banding. 2 to 3 further injections can be required, free from major complication. So this will be injected into the submucosa. As you see here, you can give sclerotherapy with the help of a colonoscope or in retrovision or using anoscope or proctoscope also. The injection is usually around 3 to 5 ml into the submucosa, which produces you must give it above the dentate line, otherwise pain is horrible, and fibrosis will come, shrinking of hemorrhoid, fixation of the hemorrhoid to the underlying internal sphincter is the result. The most successful, particularly sclerotherapy in grade 1, grade 2. Dull pain may be there with paracetamol, it will go off. Sepsis rare unless you take care of the aseptic methods. Surgical intervention, IV antibiotic for those people. Suppose if the patient has got AIDS, then if probably patients, the sclerotherapy is preferred to banding because of the complications. Studies also recommend that both effective and safe in the treatment of grade 1, 2, and 3 hemorrhoids. Cryotherapy, I will omit because nobody practices. The reason is, of course, the time-consuming procedure, cost prohibitive, expertise mandatory, and foul-smelling discharge resulting from tissue necrosis. His patient is not very happy. Compliance. Infrared coagulation is, of course, it leads to fibrosis. 1.5 to 2 to 3 sites, the proximal to the hemorrhoidal plexus. Multiple sites can be treated at the same visits. Most useful for grade 1, 2. Results comparable to almost banding and sclerotherapy. It is not neither superior or inferior. Larger hemorrhoids do well with treatment also. Complications are less. This is the laser therapy. You will find laser treatment, separate hospitals also, and even in small towns you are seeing, but the problem is cost. Now, advantages of laser is minimal blood loss, minimal pain, quickly done office procedure, no need for hospital stay, quick healing, low chances of damaging other tissues, precision-based treatment. That means laser beam is so thin and precise, it goes to the target area. But it does have disadvantages, costs. Then each laser fiber, once you use, you got to again replace. That's costlier, and expertise is needed. What are the indications for surgery? All above methods. Conservative method, drugs, then of course the non-surgical, non-removal, excisional procedures all fail. What is that you are going to do? Excisional hemorrhoidectomy, particularly for grade 3 and grade 4 hemorrhoids who are not responding to above measures. Symptomatic, external hemorrhoids, unresponsive to conservative therapy. Long-term outcome, success rate, thanks to the surgeons, more than 85% on 10-year follow-up. The procedure for prolapsing grade 3 and grade 4 hemorrhages, of course, more than 75%. If you want to compare the laser and the traditional pile surgery, hemorrhoidectomy, minimally invasive, cuts or stitches, no, same-day discharge, post-surgical pain is very minimal, recovery is quick, blood loss is not there. Whereas in traditional surgery, minimally invasive, no, it is a planned one, elective one. Then you do stitches or laser also can be used there, or coagulation, and of course diathermy. And the same day discharge, they may keep for 2 or 3 days. Post-surgical pain may be very, very horrible. I have seen people, when there is a raw area, it takes months to heal, and it's a suffering like anything. I had to see one patient where I had to apply lidocaine ointment 10 times a day, apply to give good relief of sleep. Not only the patient is devoid of good sleep, the relatives also in the house, attenders, as well as the doctor who operated. This fellow goes on talking to you, pain, pain, pain. So when it goes to the internal sphincter and damages the sphincter, it can produce stricture also. So recovery, it takes a few weeks, and blood loss can be there sometimes in all highly potential group. I think I have taken much time. I can't avoid. I always have hunger for mic. Sorry for the delay. So the messages I wanted to tell you in short: vascular cushions normally present, normal there. It is asymptomatic, no treatment. Hemorrhoids or varicose veins, prolapsing, and cushions come down, intraanal pressure goes up, and internal pile masses can even cause bleeding, pain, prolapse, etc. Painless intermittent bleeds, piles may prolapse, anal pain and itching may be there. External piles, asymptomatic, thrombosis with bleed has to be dealt, itching may be there. Diasamine with hesperidine, 60 to 75%, easily you can expect a good benefit in these people, success rate in grade 1, 2, 3 piles. Mostly, I manage my patients in my office practice in a period of 6 to 9 months with good follow-up in degrading the hemorrhoids. In fact, my surgical colleagues are angry with me that I am not referring the patients. 4 grades of hemorrhoid, fourth grade, 4 grades, they need hemorrhoidectomy, very important. So I thank once again for the opportunity given to me to Walter Bushnell and to those listeners with interest. Thank you so much. Leave it to Professor PREM to add or less or comment or how can I improve my talk next time. Thank you. Thank you.
Thank you, sir. Thank you very much for the excellent and lucid talk. I hope everybody would agree that sir has covered the entire topic and nothing must to be discussed about, starting from the clinical history, diagnosis, importance of preventing a hemorrhoid to develop, and the various local treatments, drugs available, and non-surgical management of treatment of hemorrhoids is dealt with extensively. And in fact, his experience has come forth and he has dealt so nicely regarding the usage of local medicines and then like ointments and diosmin based medication for the treatment of hemorrhoids. He has nicely dealt with everything. And as I would, to sum up, I don't have anything extra to add, sir. So probably good clinical history, and every bleed per rectum is not always hemorrhoid. I think especially in an elderly person, it is better to do, as sir told, a digital rectal examination is must in all cases of bleed. And if need arises, you'll have to do a scopy to rule out other causes. As he told rightly, apart from right anterior, right post, and left lateral, if you see any other mass in the anal leather, you have to do a procedure to rule out other causes of bleed, unless otherwise we'll be in deep trouble. And the most important thing, with the advent of the software industry, as rightly mentioned, and people sitting for a longer time, and people taking a lot of junk foods, it has become the order of the day, and people started eating less fiber in the diet, and they take less liquids because they go to the office, sit there, they tell, I'll have to go to the toilet often. That is not an excuse for taking less fluids. So as sir told, he should make sure that at least drink 8, if need arises, more than 8 glasses of water also in a day with a lot of fiber in the food, so that you can avoid all these complications of developing a hemorrhoid. And as he told, sitting for a long time, you get up and then walk around for some time. And apart from professions wherein standing requires a long time standing, that cannot be helped, but other things can be avoided. So as rightly put, I think this disease can be prevented if a proper lifestyle modification is adopted, sir. And thank you very much for the excellent talk. I think of my student days, sir, wherein do you take lectures and in our meetings also. And thank you very much, Walter Bushnell, for the opportunity to listen to sir. And then and I hope everybody would have definitely enjoyed this talk. And whatever doubts they had, I think it should have got cleared by now. Over to the delegates, and thank you, sir. Thank you very much.
Thank you, sir. Thank you, sir. Sir, we have one question which Dr. Colin has asked. Dr. Colin N. He writes, can laser be used for 3rd grade hemorrhoid?
Laser?
Yes, sir. Yes, sir.
Yeah, they use it for anything.
Okay, yes, sir.
Right. Only thing is, laser should be handled by the experienced person, identify the foci, and every time they have to replace the laser.
Yes, sir.
It's very costly.
Yes, sir.
And one more thing I would like to add, sir, and probably nowadays we started using the Western type of toilets. Once we had Indian type toilets, constipation not at a problem at all. Now people go to the toilet and they take a book, they do all the office work in the toilet. As rightly put, if you stay in the toilet for more than 5 10
Children
minutes,
play also with the mobile addicts.
all these things should be avoided, sir. And people do a lot of work in the toilet rather than the drawing room or whatever room they have to do work. That's a problem now.
I am very favorite to use the terminology for what you have suggested, Kansti Upasana posture.
Voices, sir. Put a stool.
They have to practice.
They have to, sir.
The knee must be up when compared to the anus. That's enough.
That's enough.
Nobody sits. And if they sit in a Western closet, probably they have to use a footrest to see that the knee should be, the thigh and knee should go up. They can bend little, do like that. Talat padina,
Prevention is always better than cure, sir. That's all.
Always better, but not practiced. That is the one, that is the uphill task. Very happy. Arun, can you
Yes, sir.
finalize? And you want to acknowledge listeners
Yes,
and
sir.
others?
Sir, on behalf of Walter Bushnell Healthcare Foundation and on behalf of all the audiences who have gathered this
How many people?
noon, we have around
30 members. 30 members were.
Plus, since it will be there in YouTube, so there will be more viewers in that also. And we would like to offer thanks on behalf of everyone to Dr. SANKARANARAYAN. Sir, we are thankful for you, thankful to you for finding out time and talking to us on this really important topic, right? And we are also very thankful and grateful to Dr. KUMAR, sir. So and sir, now with your permission, we would like to end the session over here.
Thank you.
Yeah.
Thank you.
Thank you, sir. Thank you for your valuable time and the very wonderful presentation. Thank you so much, sir.
Thank you for the opportunity.
Thank you.
Thank you very much, sir.
Thank you,
On behalf of
Premji.
Chennai. Thank you, sir.
Thank you, sir. Thank you.